I've been a doctor for the last 21 years, and this is my first consultancy in East Kent. I've been here over a decade. So I lead the stroke services, and the reason that I've taken time out this morning from chairing a neurovascular multidisciplinary meeting is that I've been involved in some of the transformation of this organisation when it was put into special measures 3.5 years ago. Because I'm one of the clinicians that passionately believes in the NHS. I don't undertake any private practice. I'm dedicated to the NHS. And I hope to be here for the next 20, 25 years practicing medicine. Now, I need to make sure that the people who make the decisions, which are the politicians and the CCG, get this right. Get this right for you as patients and me as a healthcare practitioner, because that's my passion. So I also practice general medicine and geriatric medicine, so I've got quite a large remit. My special interest is stroke medicine, and that's one of the topics that has been very, very interesting recently. And I also lead the national review body, which has just published guidelines regarding the best treatment for stroke medicine. So there's no doubt that you're fortunate in East Kent that we are top of the game when it comes to knowing what we should do. The reality is we haven't quite been able to do as much as we wanted to do at the moment, which is why we need to make some changes. So there are 3 key points that I'd like to get across about why we need to make some changes within hospital medicine. Simon's alluded to that earlier, but one of the key factors is there's inequality in East Kent. Some patients are twice as likely to get admitted to hospital than in other regions in East Kent, purely because of the inequity in primary care. Now that's wrong, and I passionately believe in quality of care for everyone, not just pockets about where you live and what your postcode is. Everyone should get equality. There's another truth that if you're older and frail, for every 10 days you spend in hospital, your muscle mass wastes approximately up to 10 years. Now fortunately we can correct some of that with rehabilitation, but it takes weeks and months. So lying in a hospital bed is very bad for you if you don't need to be there. There's another truth, and a reality, is that our social and healthcare service at the moment is failing you because we have up to 300 patients in our over 1,000 beds who don't need to be there. And that's not their fault, that's not your fault. That's because we in health and social care have not been organised enough to allow those patients to go home when they're ready. And it's nodding around the audience, because some of you may well have been those individuals, and I as a practicing clinician daily find that there's patients that are finished with regards to the acute care, but they can't leave hospital, not through their fault, but because we can't organise the social care and the package they need. And we need to get that right. That's wrong. And together with social care and CCGs, we will make those changes, but we have to make those changes. So, what we've done is we've listened, and I think it's really important. Over the 21 years I've been a doctor, I don't think I've ever worked in an environment where we listen more. We really do understand that great healthcare is not just about whether you survive, whether you are less disabled. It's about your experience. It's about how things were for you. And there's no doubt if you aren't communicated to, told what the future holds for you, even if you do have a good outcome, you're really frustrated and upset. And interestingly, we can do so much about the communication. So we have been listening, and there's some key factors that we've learned. What we've learned is you want best care. So throughout all of this, and the compliments I read, the complaints I answer, it's all about I want high quality care. I want high quality care, the best we can get in the country. Number one. Number two, you actually want it closest to home. And I agree with you entirely. We should provide best care closest to home. You also want access. You want to be able to get to hospital quickly when you need to, and you also want to be able to leave hospital quickly when you need to, and not have delays, artificial barriers put in place. So, what is the suggestion? So, the suggestion is that in the future, we will be able to speed up your admission to hospital, get you to hospital very quickly. We will make sure that when you are in hospital, you see a specialist team. Now, again, so over the last 21 years, there's so much that has changed in healthcare. So much. You take myocardial infarction, stroke disease, the things that we can do now, we wouldn't have dreamt of when I graduated from medical school. The reality is that it needs a specialist team to do that. I'm qualified to treat a whole range of medical conditions, but I do know that the outcomes for some of those medical conditions that I'm accredited to treat are better in specialist hands. Now, although I can treat you, you're better off being treated by a specialist for coronary artery disease, for example. Certainly my colleagues could care for you if you had a stroke, but you're better off in my hands. So you need specialist care, and you need that within minutes, not the next day or the next week. You need it as soon as you get to hospital, and that's what we plan to give to you. Along with the specialist care, it's the access to the treatment, the infrastructure. Again, there's lots of things we can do now that we need the infrastructure, the fancy radiology, the interventional arterial treatments. We can't provide them in a GP practice or in a small hospital because they cost millions, and we only need one of some of those interventions. Once you've had your expert care, we need to work really closely with your GP and community teams so that when you're ready to leave hospital and continue your recovery journey, you get home, and you get home quickly, and you don't lie in a bed, you don't see a physiotherapist for an hour a day, you actually get home and are practicing your rehabilitation every single day. And the evidence speaks for itself. You take stroke disease, you do better the quicker you get home, full stop. And any of you who are doubting any evidence, we can chat about that later, but it's absolutely crystal clear. Those areas that have got really good early supported discharge, the outcomes for patients at 6 months and a year far outweigh those hospitals that keep people in their beds for weeks on end. So, what are the proposals? The proposals are, and these are our early thinking, and this is not the consultation period, this is about us listening to you and making suggestions. We plan that in the future there will be a super hospital which has all of those highly specialised, expensive pieces of equipment and specialist teams together, co-located, so that if something goes wrong after your heart attack, your stroke, you don't get put in an ambulance and sent somewhere else. Everything is on site. And the evidence speaks really clearly that that's the best way to reduce complications. We also know that one hospital is not going to be enough for East Kent. We need another emergency hospital, which has an accident emergency department, it has medicine, it has lots of other highly specialised inpatient services to care for you, but not some of the highly specialised services. Our other suggestion is for those conditions where you need absolutely first-rate, cutting-edge elective care, you need it provided in a hospital that is not burdened to the flux of emergency admissions. So think about urology, elective orthopaedics. Those conditions where you plan your care, you need an operation, you need to go to a hospital that will always have a bed for you, will always have the appropriate room for you, the appropriate single-sex ward for you. And you won't have to get a phone call the morning of your operation to say, I'm really sorry, we had a busy night. There was a terrible accident on the M20, we haven't got any beds for you. But that's what happens at the moment. 250 orthopaedic operations were cancelled last year because we had major events in East Kent and people were very, very sick. And we said, I'm sorry, we can't do that knee replacement or orthopaedic surgery because we need the bed for someone who's critically unwell. And that's about managing our situations we've got now, but that's not good for you if you're waiting for your hip replacement. So, I'm going to talk through 4 key areas that we are confident will change with some of these suggestions. So, stroke care, and I'm looking here, I have to be careful I don't run over time. Stroke care. So at the moment, you've got a pretty good stroke care service within East Kent, which I'm really proud of. However, it can be better. There's no doubt it can be better. At the moment, you will be, if anyone suffered a neurovascular event, CCAM will be with you very, very quickly. You will get delivered to one of our HASU services, which used to be on all 3 sites. And for the short term, there's only 2, so QE and the William Harvey. And within minutes, you will see a stroke consultant either by telemedicine or in person, and we will perform a brain scan. And if you need to have the clot-busting drug, you will have it again within minutes. You will then get to a stroke unit, again within 4 hours. Do we do that all the time within East Kent? We don't get there all the time, but 80% of patients get to our stroke units within 4 hours. That's not good enough. Why is that the case? Well, at the moment, we've got lots of patients who need to be in hospital but haven't had a stroke on our stroke units because we haven't got enough beds for them elsewhere in the hospital. So that needs to change. Once you're in hospital, within 24 hours, you will have some detailed assessments, make sure that the complications that occur after stroke don't occur, and we feed and we rehydrate patients. And within 72 hours, you have a whole battery of rehabilitation assessments that will be completed. That's what happens now, and it's pretty good, but it can be better. What does the future hold? Well, we expect that you will have those assessments a lot earlier. You won't be sharing a stroke unit with people who haven't had a stroke. It'll only be those people who need to be there. And we will have 7-day access to consultants and therapists. At the moment, we can't staff that over 3 sites. For the last 3 years, I've been working 1 in 2 or 1 in 3 weekends because my colleagues on the other sites have been trying to work 1 in 2, 1 in 3 weekends. Now that's not sustainable. So let me tell you a story. So, this isn't Bill, that's not his name, but this is a real patient and that's not his picture. But of course, at the moment he has, if he were to have a stroke, he gets everything that I've highlighted to you. He gets it all really quite timely. But in the future, he will get his access to thrombolysis within 30 minutes. Now, some people say to me, is that really doable? Well, it is doable because last week I treated 2 people 15 minutes to 16 minutes because I was there personally and I met them at the door. So I know it's possible and it does happen, but it doesn't happen 7 days a week, every day of the year, because we're stretched over a number of sites. Do you have therapists working on Saturdays and Sundays at the moment in the stroke units? No, we don't. Why is that? It's because we've got too many stroke units open and they can't spread themselves over all of the sites. In the future, you will do. You will see a doctor on a Saturday and a Sunday at the bedside to talk with you about your condition, but also, most importantly, make some of those subtle changes that we can't do via telemedicine and communicate with the therapists. And the great news is the evidence from other centres that have done this demonstrate a significant chance of survival and also returning home functionally able. So the evidence is crystal clear. Let's talk about emergency care and medical care. So at the moment, we know that there are an increased number of patients that go to A&E, a real need to be seen by a doctor. I'm not confident that they do actually need to be seen by an emergency doctor. And in fact, if we had better access to primary care, a lot of those patients wouldn't need to be there. We know that you have to wait too long in A&E. And again, yesterday I was in A&E and there were people who were waiting over 4 hours. Now that's wrong. You shouldn't have to wait that long. We need to have emergency departments that have the right people there, specialist people there to care for you, and you get seen quickly, really quickly. You shouldn't have to wait. Now, yes, of course, it's a lot better than it used to be, but it can be better and it should be better. We also know that the benefit from having specialist care early means that you get the right diagnosis, you get the right treatment plan, and the chances are you will have a better outcome. So, let's talk about a medical patient. So, this is someone, again, Douglas isn't called Douglas, and that's not his picture, but this is a real patient. So he's 74, and he's had some falls, and he's seen his GP. What happens is he has another fall, and his relative calls CCAM. He gets brought to hospital, but because he's 74, he's not classed in our arbitrary manner as being an older person. He's considered as being under general medicine. He doesn't see a geriatrician, a frailty expert. He sees a general physician. So, for example, a cardiologist that's doing general medicine. Now, they're great at their hearts, but they're not experts on frailty and falling. So he comes into hospital, he has various assessments, and in fact, he may have been ready to go home if he'd had the right assessments, but he doesn't see the specialist. Once he's in hospital, it's a new environment, he becomes confused, that's what delirious is, and before we know it, Douglas is spiralling into an inpatient episode which could have been avoided. Now the reality is, I see this, unfortunately, probably once or twice a month. And since I've been in East Kent, I've cared for about 3,000 patients with geriatric needs. And this is all too common, and it's wrong. We should do better, and we can do better. So what will the future hold? And we're already implementing pilots of this across East Kent. When Douglas has his next fall, instead of being sent straight into A&E by CCAM, he's seen by a rapid response team at home that is equipped with multidisciplinary staff. He may well actually need to come straight to hospital for assessments to make sure he hasn't broken a bone. But when he gets there, he doesn't see a general physician. He sees a specialist, a frailty expert. And that expert, who will be a doctor, will have a multidisciplinary team with them. They will go through all the needs that Douglas has. They will make sure they check in great detail the drugs that Douglas is on, because we know an awful lot of drugs that patients take can make them fall. And before we know it, we find that Douglas hasn't broken anything. We can change some of the medicines. We may have to rehydrate, give Douglas a drip for a few hours, but we can actually, with Douglas's support, get him home. And that's actually the best outcome for Douglas. Now, this does happen, and again, I've had patients where favours pulled lots and lots of strings. We get all those assessments done, and we do get patients home. But I have to fight hour on hour during that acute medical stay to get that to happen. Now that's wrong, and that's not sustainable. We should have a system that allows us to do that for every single patient, not just the lucky ones that happen to have Dr. Hargroves, who's got a bit of time and he's going to fight for you. Everyone should get that. Let's talk a little bit about orthopaedic care, and I alluded to this before. We have a lot of patients who fortunately are living longer. Great. The reality is you've all had really active lives and your joints may well wear out. The great news is orthopaedic surgery has come a really long way, and there are some fantastic joint replacement surgery that we can offer that in fact we can do, and it may well be a matter of days, if not even on the same day that you get to go home. You should never have to have your operation cancelled if it can be avoided, because we haven't got a bed for you. And our plan is that we're going to avoid those cancelled operations. We're also going to avoid you being on a ward where potentially there are very sick people who've had accidents with vehicles that have got lots of infections, and then you pick up that infection. And again, the evidence is really clear from those super specialised elective orthopaedic centres. The patients do better than in a general hospital that's got lots of other emergency care. So let's take Mary. Okay, this isn't her name and that's not her picture, but this is her story. She's got joint discomfort. She gets referred from a GP to an orthopaedic specialist who says, yes, I think you need a joint replacement. She then gets put onto a waiting list. She gets reassessed at another time. She then has a date for her operation. And incidentally, our wait now for orthopaedic surgery, you can wait between 21 and 27 weeks for a joint replacement. That's wrong. We can do better. I know, that's terrible. We can do much better than that. She gets her operation date, and on the day before, she gets a phone call to explain exactly that. I'm sorry, we can't have you today. It's going to be a few more months. Now that doesn't help Mary with her pain. She's empathetic because she knows that people potentially have life critical conditions in her bed. But that doesn't help Mary, and we can do better. In the future, Mary won't have lots of appointments to see junior, then senior doctors. She'll have a one-stop assessment, and at the time of assessment, hopefully with a member of family with her, we will check our diaries, we'll have an electronic system, and we'll say, what date works for you? When would you like to have your operation? And it won't be in 21 weeks, 28 weeks. It will be in the next few couple of months. And we set the date. And because it won't be in a busy general hospital, it will be in a super elective hospital that doesn't have emergency admissions, we can pretty much guarantee, not 100%, pretty much guarantee that you will have your operation on that day. And because the doctors and nurses and therapists that are caring for you are not also rushing around with the emergencies, that's all they're doing. They're caring for you. There's a high chance that actually, when we say you'll go home the next day, you will go home the next day. Because the people, the staff we've got caring for you have not got to rush off for emergencies. Now, this isn't visionary thinking. This is common practice in some areas of this country. Now, what's interesting is when they had to go through this period, there was lots of uncertainty, but when you look at the evidence, highly selective, elective surgical hospitals have better outcomes. It's a fact. We want to have that opportunity here for you in East Kent. So, the future is bright for East Kent. It's really bright. It's bright because there's lots of individuals like me who are going to ensure that it's bright for you. This isn't about actually the politicians and the managers. It's about us healthcare practitioners ensuring that they get it right. I don't make the decisions, but I can assure you I'm knocking on the doors ensuring that they make the right decisions. You will get better care, quicker care, and you will get home quicker. And the chances are, therefore, you will have a longer life that is of higher quality. It's now time for us to listen to you. Thank you.